Preoperative anemia affects up to 40% of patients undergoing major elective surgery. It's a highly prevalent, modifiable condition, operating as an independent risk factor. Patients entering the operating room with uncorrected anemia face statistically higher rates of 30-day mortality, acute kidney injury, and prolonged intensive care admissions. The deficit in oxygen carrying capacity leaves organ systems highly vulnerable to surgical stress. To mitigate this, international clinical guidelines now mandate a specific, unified baseline for patients scheduled for moderate to high blood loss surgery. The target preoperative hemoglobin threshold is strictly set at 13.0 grams per deciliter. Crucially, this threshold applies universally to both men and women. It discards the legacy definitions that previously normalized lower blood counts in female surgical patients. Proceeding to major surgery below this 13.0 standard directly increases a patient's statistical probability of requiring allogeneic red blood cell transfusions, introducing entirely preventable risks into the surgical pathway. For decades, clinicians relied on the World Health Organization's diagnostic thresholds for anemia, which accepted 12.0 grams per deciliter for women and 13.0 for men. While useful for population-level screening, accepting a 12.0 baseline for women in a surgical context creates a dangerous physiological deficit when accounting for the mechanics of operative blood loss. The primary metric governing surgical tolerance is total circulating blood volume. On average, female patients possess a lower total blood volume than their male counterparts. This animated diagram illustrates the mathematical reality of the operating room. If both a male and female patient lose exactly 500 milliliters of blood during a procedure, that identical volume represents a significantly larger percentage drop in the female patient's total red cell mass. The 13.0 grams per deciliter threshold is required to build a sufficient preoperative erythrocyte buffer. It establishes physiological parity, ensuring female patients avoid a disproportionate risk of hitting transfusion triggers. Detecting low hemoglobin is only the initial step. The preoperative screening clinic is responsible for identifying the specific etiology of the anemia so it can be targeted and reversed. Relying on mean corpuscular volume, or MCV, is insufficient in this setting. MCV measures the average size of red blood cells, but many surgical patients present with normocytic anemia, where cell size appears entirely normal despite severe underlying iron depletion. A precise diagnosis requires a comprehensive laboratory panel, a complete blood count, serum ferritin, transferrin saturation, vitamin B12, and C-reactive protein. Transferrin saturation, or TSAT, measures the percentage of transferrin proteins currently transporting iron in the blood. C-reactive protein, or CRP, is a biomarker that indicates the presence of active systemic inflammation. Uncomplicated absolute iron deficiency is straightforward to diagnose. It is defined by a serum ferritin level below 30 micrograms per liter. However, ferritin is an acute phase reactant. In patients with chronic disease, malignancies, or any active inflammatory state, ferritin artificially elevates, masking a severe iron deficit. This cellular-level diagram demonstrates functional iron deficiency, or iron sequestration. During inflammation, the liver produces hepcidin, a hormone that regulates iron distribution. High hepcidin levels instruct macrophages to trap iron internally, preventing it from reaching the bone marrow for red blood cell production. In these patients, ferritin will read above 100 micrograms per liter, but TSAT drops below 20. Pharmacological intervention is triggered when laboratory values fall below these strict cutoffs. Ferritin under 100 micrograms per liter in the presence of inflammation, B12 under 270 picograms per milliliter, and folate under 3 nanograms per milliliter. For elective procedures, the final nodes of the algorithm mandate a terminal action, postpone the surgery, and prescribe targeted supplements. Adhering to this structured sequence ensures every elective patient arrives in the algorithm room with an optimized hematopoietic profile, ready to withstand surgical blood loss. Once an iron deficiency is confirmed, the specific route of pharmacological intervention is dictated entirely by the time remaining until the scheduled incision. If the surgical date is greater than 6 weeks away, the first-line therapy is oral iron supplementation. Current protocols advise moderate dosing, 40 to 80 milligrams of elemental iron, administered every other day rather than daily, to maximize gastrointestinal absorption. This chart comparing hepcidin response curves shows why. A daily dose of oral iron triggers a continuous hepcidin spike, which blocks further absorption in the gut. Alternate day dosing allows hepcidin levels to return to baseline, creating physiological troughs that permit efficient iron uptake. If the patient cannot tolerate oral iron, or if surgery is scheduled in less than 4 weeks, intravenous or IV iron becomes the mandatory standard of care. IV iron bypasses the gastrointestinal tract entirely for rapid store replenishment. Dosing is often calculated using the Ganzoni formula, which determines the exact milligram deficit of iron based on the patient's body weight and target hemoglobin. In highly refractory cases, or before procedures with massive expected blood loss like cardiac bypass, clinicians may deploy erythropoiesis stimulating agents, or ESAs. ESAs are injectable medications that directly signal the bone marrow to accelerate red blood cell production. Matching the administration route to the surgical calendar guarantees that the intervention has sufficient time to physically build the required red cell mass before the day of surgery. Preoperative optimization builds the patient's red cell buffer. As the patient enters the intraoperative phase, the clinical focus shifts entirely to hemostatic conservation. The modern standard for patient blood management dictates strict adherence to restrictive transfusion strategies, aggressively limiting the use of allogeneic blood. This diagram of a surgical transfusion monitor shows the primary trigger point. For patients with active major hemorrhage, red blood cell transfusion is withheld until the hemoglobin level drops to 70 grams per liter, targeting a post-transfusion range of 70 to 90. This threshold is adjusted slightly for patients presenting with acute coronary syndrome, a sudden critical reduction of blood flow to the heart. For these highly vulnerable patients, the trigger is raised to 80 grams per liter. When a transfusion is absolutely necessary, best practice requires administering a single unit of blood, followed immediately by a rigorous clinical and laboratory reassessment before any further units are released. Extensive clinical trial data confirms that these restrictive strategies effectively reduce overall transfusion rates without increasing patient mortality or postoperative morbidity. Alongside strict transfusion triggers, surgical teams utilize systemic hemostatic adjuncts to preserve the patient's existing red cell mass at the operative site. For adults undergoing major inpatient surgery, the standard protocol includes the intravenous administration of 1 gram of tranexamic acid, or TXA, immediately prior to the surgical skin incision. TXA functions as an antifibrinolytic, a class of drugs that prevents the breakdown of blood clots. By stabilizing the fibrin matrix, it directly reduces major surgical bleeding and sharply decreases the need for subsequent blood transfusions. The perioperative anemia pathway operates on 3 distinct pillars: rigorous preoperative identification, algorithmic diagnostic categorization, and targeted intraoperative conservation. Preoperative anemia is a highly correctable pathology. Aggressively managing it through these established evidence-based pathways ensures patients face the physiological stress of surgery with maximum resilience.